Okay, Justin, are you ready?
Yep, I'm ready.
We will get going and
Sure,
see if some attendees join on the fly.
sure,
Um,
sounds good.
so, hello everyone. Welcome to a new year of What's New in Addiction Medicine seminars. My name is Paxton Bach. I am the Associate Director of the Clinical Addiction Medicine Fellowship Program, and I will be facilitating today's session. We'll get going. I know that people will kind of join in as we go. I would ask just as first questions go, feel free to type questions into the chat throughout the talk. We will be collecting those. Justin may answer some of them on the fly. Otherwise, we'll have a period for questions at the end of the talk. So with that, I will introduce our speaker for today. So this is our first What's New of the new fellowship year. So I'd very much like to thank Dr. Coe for joining us. Dr. Justin Coe is our presenter today. He's an addiction medicine fellow with the BC CSU Clinical Addiction Medicine Fellowship Program. And he's also a Royal College Emergency Medicine resident at the University of Saskatchewan. So we borrowed him for a year out here. He studied medicine prior to his residency at McMaster University and has also recently completed a Master's of Public Health at Johns Hopkins University. He's passionate about improving addiction care and harm reduction services in the emergency department setting. And he's joining us today to talk about a very topical subject, I think, which is navigating cannabis harm reduction in post-legalization Canada. So with that, I will let you take it away, Justin. And as I mentioned, please feel free to type questions in your chat box as we go.
Perfect, thanks Paxton for that introduction. So welcome to everyone who's joining us over Zoom today. And I'm excited to present my talk today on cannabis harm reduction in the post-legalization context in Canada. Let's see, the slides might be lagging a bit. Let's see here if that works. Okay. So I moved from Saskatoon to Vancouver, so I think it's even more important that I acknowledge that I'm a humble guest on these unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. And you know, a lot of you might be calling outside of Vancouver, so I hope you can take this moment to acknowledge the lands that you are on, wherever you may be right now. I don't have any conflicts of interest to disclose, and more importantly, I don't have any interest in or money received from cannabis companies. And I'd like to also thank the healthcare providers who helped me prepare for this talk today. So, you know, we chat about different ideas. Thanks for sharing your knowledge and your expertise and for taking the time to review the slides before my talk today. So in terms of the learning objectives today, I'll begin by presenting some data on cannabis use pre and post legalization in Canada. And then using 3 interactive cases, I'll be highlighting some practical approaches to cannabis harm reduction in different clinical settings, outpatient, inpatient, in the emergency department as well. We'll touch on cannabis use disorder briefly, but that won't be the main focus of this talk. My goal today is for you to leave, feeling more able and excited to provide cannabis harm reduction in your practice, whatever that looks like. So as I mentioned, we have some interactive cases, so we're going to try this out. If you look at the link on top, you can use it on your phone or on your computer. Go to www.menti.com, and if you put that code in, there's going to be a voting option and you can choose. So this is a trial question. We'll start with, what year was cannabis prohibited in Canada? And as people start putting in their answers, it should show up automatically in the system. It's just a way of making this presentation more interactive since we're chatting virtually this time. Okay, worked for one person. So give that a minute to see if that works for everyone else. And then if you keep that link open on your phone or your computer, we'll come back to it a few more times throughout the talk today. Okay, I'll let some of you figure out if that works on your phone or on your computer for the later questions. This is just a trial question. Feel free to type stuff on the chat as well. Any questions, feel free to interrupt anytime. And so what's the correct answer? So most of you voted 1923, some 1945, 1956. So cannabis was actually prohibited in 1923. And I think, before we take a look at the context pre and post legalization, it's really important to remember that the historical context of drug prohibition in Canada really matters, and because those contexts continue to shape society today, it continues to inform, our approach in many sectors of society towards drug use. And we really can't forget the fact that drug prohibition in Canada has always gone hand in hand with racism. If you look at the picture on the right there, a year after the anti-Asian riots in Vancouver in 1907, that was when the Opium Act was introduced. And, opium was described as this yellow man's evil drug that was used to corrupt white people, and Asians were disproportionately prosecuted for drug possession. And we really continue to see the disproportionate impact of racism towards Black, Indigenous, and people of color in Canada today. And we definitely see the racism that continues to be perpetuated towards Indigenous people, especially during the time of the opioid epidemic. So the Opium Act was introduced in 1908. Cannabis was added to the act in 1923. It wasn't until 2001 that medical access to cannabis was granted after a Supreme Court ruling. In 2018, so on October 17, 2018, that was when cannabis was legalized. And a year after that, the legislation was expanded to include edibles, topicals, and extracts. So a lot of our post-legalization data on cannabis use in Canada comes from the Canadian Cannabis Survey. It's a survey that was designed in 2017, and it's been conducted annually since then. Before that, there were two surveys that were used, to look at tobacco, alcohol, and drug use, but they weren't really designed to collect information specifically on cannabis use. And so the new Canadian Cannabis Survey was created. So in 2018, about 4.5 million people in Canada reported using cannabis, and that's gone up to about 5.1 million in 2019 after legalization. And when you look, I made these graphs to help you visualize the data a bit better. You can see that post-legalization, the only age group where the cannabis use in the past 3 months went down significantly was in the 15 to 17 group, which is a good thing. But overall, cannabis use has increased, particularly among people aged 25 and older. When we take a closer look at the daily or almost daily cannabis use that's self-reported in this survey, we can see that levels have remained pretty similar before and after legalization, with the exception of those who are 65 and older, and a small increase from 1.6 to 2.6%. The data didn't collect a lot of qualitative information. We don't really know why that went up, but I think it's something we should pay attention to and see what happens as more data is collected in the upcoming years. So when you look at kind of just that pre and post legalization snapshot, it might be easy to attribute, the increase in prevalence to legalization. But when we look at available data in the years prior, so up to 2004, I think you can actually see that there's a positive trend, a positive increase in cannabis use that preceded legalization. So I don't think that it's, after legalization, suddenly everyone's using more and more weed. The prevalence was increasing already. We can see that starting at about 2012. And, the fact that more and more Canadians are using cannabis each year is really something we need to pay attention to as healthcare providers. And without going into the decriminalization versus legalization debate, there are many benefits to ending drug prohibition, especially from a public health perspective. But when cannabis is becoming more and more mainstream in Canadian life, we need to ensure that our patients, clients, consumers are making informed choices when it comes to cannabis use. And that's really the basis for my talk today. How do we provide harm reduction and reduce the harms associated with cannabis use? So we'll start with the case now. The first case takes place at an outpatient clinic. You're seeing Frank. Frank is a 31-year-old male who comes to you and says, "Hey doc, I tried vaping instead of smoking cigarettes and I love it. I've been smoking weed since I was a teenager. I'm at a couple of joints now and I really don't think I could sleep without it, and it makes me anxious as well. I'm wondering if I should just vape my weed." And so going back to the interactive slide, if you still have it on your phones or computers, my first question for you is, does Frank have a cannabis use disorder? So you can vote using that app. There's a yes, there's a maybe. Thanks for the participation. Yeah, better numbers than the first slide. That's awesome. Okay, so I'm seeing a lot of maybes, several yeses, several nos. So I would say that Frank might have a cannabis use disorder, but we need more information before we can confidently say, yes or no. In the case, he says he's at a couple of joints a day now. So I think we need more information on how his tolerance has increased and sort of what timeline does that look like. And he might have some withdrawal when it comes to anxiety or insomnia, but we really don't have a good sense of how cannabis use is affecting his life, his work relationships, his family. There are a set of DSM-5 criteria for cannabis use disorder, but they can be quite hard to apply for cannabis use, especially because we see a lot of people who are heavy daily users of cannabis, but they're very functional in their work, in their social lives. And so it definitely takes a few more visits to, especially involving, family members, partners, to really characterize how cannabis use affects someone's life, if at all. So I'd say maybe. Briefly touching on pharmacotherapy, so medical treatment options for cannabis use. So we still don't have any medications that are approved for treating cannabis use disorder. So our options are quite limited. There are, small studies, case studies that have shown possibly some benefit for certain medications like gabapentin, N-acetylcysteine, or NAC that we commonly use for, we see in Tylenol overdose treatment, so the same NAC but taken by mouth. And there's inconsistent evidence for replacement therapy using cannabinoids, so nabiximols, nabilone, your synthetic cannabinoids. I won't be going into really a lot of detail on the evidence for these medications, but I included the references here for you. There's a really good systematic review. We have a Cochrane review in 2019, but the systematic review that was published earlier this year kind of goes into a good overview for each substance and the data around it and whether or not we have enough information to say yes or no. So you can take a photo of that link, and I'd encourage you to review that in your own time. So if we don't have any great medications that can treat cannabis use disorder, what about our psychosocial interventions? So a Cochrane review in 2016 looked at 23 randomized controlled trials and that involved a total of 4,045 participants. And really, in summary, the best evidence is for a combination of cognitive behavioral therapy and motivational enhancement therapy delivered over a 12-week period. And even better if we're able to support that 12-week period with a contingency-based program. So a voucher-based program was found to, increase the number of cannabis negative urines in the study. These interventions combined, most participants in them completed treatment as intended. They had reduced frequency in use, reduced severity of their dependence, and some low quality evidence that they ended up using fewer joints per day. Unfortunately, none of these interventions were consistently effective at 9-month follow-up, and they really didn't impact, the cannabis use disorder itself. But I think, it's something we need to consider for cannabis use, especially when our pharmacological options are limited. However, it is pretty intensive treatment, right, that needs to be delivered over 12 weeks. And we don't necessarily have our patients don't necessarily have those resources that they can access. For those with low motivation, which is very common when it comes to cannabis use, starting with motivational enhancement therapy can be quite helpful, and then tacking on that CBT afterwards. So if we go back to our case, Frank doesn't think he has a cannabis use problem. He doesn't want to stop using. So what do we do next? And I think this is where harm reduction comes in, right? My partner made me name this case Frank because our cat is called Frank. Frank doesn't have a cannabis use disorder, but he definitely has a catnip problem. So let's move on to harm reduction. So the first point I want to make about harm reduction when it comes to cannabis use is looking at THC content. With legalization comes regulation, so we really need to know what type of cannabis products are out there on the market to understand what our patients or clients are using. When you look at the THC content of available cannabis in Canada, it's increased from about 3% in the 1980s to 15% today. And in Canada, many strains are up to 30% THC. You can just, go online and look at a cannabis store, and you'll find that many of the options really are about 25 to 30% THC. Legalization has provided some degree of regulation when it comes to packaging limits. So that there's only a maximum amount of THC you can sell in a package, and the packaging has to be smaller when it comes to your edibles extracts if the THC content is higher than a certain percentage. But when it comes to dried cannabis, there's really no limit. I think this is important because two things. The introduction of edibles, extracts, and topicals adds a further layer of complexity, not just for us as healthcare providers when it comes to understanding what our patients use, but also for our patients and clients for them to figure out, how much THC they're using on a daily basis. And the second thing is companies that sell cannabis have a financial incentive to sell as much cannabis and as much THC as possible. So part of our responsibility as healthcare providers is to mitigate that harm and ensure that our patients are making informed choices. So why does THC content matter? Many studies have demonstrated a clear dose-dependent association between cannabis use and the risk of psychosis. If you look at this graph here, it's from a meta-analysis done by Marconi and colleagues in 2016, and they found this dose-dependent association. So if you look at, those who are high-intensity cannabis users, high-end, they had almost 4 times increased odds of developing psychosis symptoms compared to non-users. So although we haven't identified, a strong causal mechanism, so we don't know exactly how cannabis causes psychosis, the evidence is strong enough, the association is strong enough to warrant a strong, strong public health messaging and really lots of efforts on harm reduction. This study I found really interesting. It was published last year, and it was a multi-center study. So they looked at 10 cities in Europe, 1 in Brazil, and it was actually the first study that looked at the incidence. So not just prevalence of disorders, but new diagnoses of schizophrenia and other psychotic disorders. And they really present some convincing evidence that daily use especially of high potency THC, so defined as THC greater than 10%, carries about a 5-time increase in the odds of developing a psychotic disorder. And you can see here, this is adjusted for other factors, the references there. And daily use, of low concentration THC is also associated with an increased odds of developing a psychotic disorder later. What was really cool about this study was it was the first study that they managed to demonstrate that in cities in Europe that had higher prevalence of daily use and use of high potency cannabis, those cities actually had higher adjusted rates of psychotic disorder. So you look at cities like London, Amsterdam, and Paris. Those are the kind of the big 3 spikes there. In Amsterdam, you have THC content weed that's up to about 80–90% as well. And so basically this in cities where people were using more high potency cannabis daily, they had more cases of psychotic disorder compared to other cities. Again, it doesn't prove that cannabis use causes psychotic disorder, but I think the evidence is quite strong, and really, as we see cannabis being made more available here in Canada and we see the THC strains going up, it's something we have to pay close attention to as well. Turning to cannabis use in driving, another important conversation to have when it comes to harm reduction is drug impaired driving, cannabis impaired driving. The previous systematic reviews found, higher increased odds of motor vehicle collision, around 3 to 4, but more recent reanalyses of those studies that were included have found that the risk is probably a bit lower, about 1.4, 1.6, so low but moderate and still significant risk of increased drug-impaired driving. The point I want to make here is that there's a big contrast between scientific understanding and public opinion and perception. So the data from the 2017 Canadian Cannabis Survey found, 50% of cannabis users don't think that cannabis use affects their driving much, and 1 in 5 actually don't think it has any negative effect at all. When you look at the pre and post legalization data, the only age group that has when it comes to driving within 2 hours of consuming cannabis, the only age group that showed a decrease was the 18 to 24 age group, which is again a really good thing. But what's kind of surprising, right? The overall, the numbers didn't really change much. So I wonder, right, with our with legalization, setting legal limits for cannabis use in the blood, with a lot of the public health messaging, really after legalization, our numbers haven't changed a lot, and I think that is quite concerning. One interesting point I wanted to bring up here is vaping associated lung injury. We think back to the case. Frank wants to start vaping his weed, and so last year we saw an outbreak of cases of vaping associated lung injury in the US. There have been a few more papers published on that topic since, and really the consensus is that although most cases had exposure to THC, it wasn't the THC that caused the lung injury, but rather the vitamin E acetate diluent that was found in the illegal vaping cartridges. And people might think that vaping associated lung injury is the same as popcorn lung, but it really isn't. Fun fact, popcorn lung is also called bronchitis obliterans, and it was first found in workers in popcorn factories who were working with the artificial butter flavoring, or diacetyl. And those were the folks who developed popcorn lung and bronchitis obliterans. But there have been no reports of vaping causing popcorn lung, in case your patients and clients ask you that. When you turn to the vaping associated lung injury cases in Canada, as of April 2020, there have only been 19 cases, and only 4 cases based on self-report were associated with cannabis use. And I think this is a benefit of regulation. With the Tobacco and Vaping Products Act, there's actually a very long list of additives that are prohibited in vaping cartridges. So vitamin E is not allowed in vaping cartridges, and that probably explains why we see a difference in the cases in the US where there was illegal vaping cartridges, unregulated content there, versus the vaping cases in Canada. However, I think it's still important for us to counsel clients and patients that they shouldn't use illegally obtained or unregulated vaping products. And when we go back to the pre and post legalization data, a lot of the government messaging about how successful legalization was, surrounds the fact that they went from 10.7% of people use legal only, like cannabis that was only legal, and then that increased to 29.4% after legalization. I think of course that's a good thing, but if you look at the proportion of people who are still reporting illegal use, that only went down from 51.7 to 40.1%. And I think that's, again, something we have to pay attention to and not just assume, that because weed is legal, our patients will be buying it from legal dispensaries. And when you look at, the Vancouver population, a recent study published in May 2020, looking at people who use drugs in Vancouver, especially in the downtown east side, they had about 900 participants, and the questions were surrounding their motivations for using cannabis, and only 0.45%, or 2 people out of 900, accessed cannabis from legal source. So it's something that we need to be mindful of. So, to wrap up this first case, I think after legalization, I think it's clear that we have an urgent duty to reduce the harms associated with cannabis use. Again, shifting from this ineffective, prohibition model to regulating access, we have now new challenges when it comes to harm reduction and improving public health. In 2018, the lower risk cannabis use guidelines were released, made by CRISM and CAMH, and it can be a helpful resource to provide to your patients. There's a lot of material you can print for your clinic as well. And the federal government, the provincial governments have created websites, for consumers to learn more about legislation, learn more about regulation and the health impacts of cannabis. But, I think where these resources fail is that they don't really provide healthcare providers with practical approaches and strategies on how you can have harm reduction conversations with your patients. So in the next few slides, I've provided some examples on how, some of the recommendations can be broached using more of a motivational approach. So when it comes to reducing the harms of daily use, instead of just being prescriptive and telling your patient, you need to avoid daily or near daily use, I think we can help motivate clients and patients by really helping them figure out whether or not there are nights when they didn't smoke or use cannabis, and then exploring those circumstances and reasons why. And this can be a really helpful approach for empowering them because, to just go from smoking daily and be told, hey, you can't do that anymore, it can be really daunting. But if we can help them identify some days or some nights when they actually didn't use cannabis, that can, we can find some reasons to motivate them and support them and help them figure out how they can do it again if they were able to do so already. When it comes to advising our patients about, using cannabis with lower THC content and avoiding illegal and synthetic products, unless we're experienced cannabis users ourselves, I think we probably don't have a great understanding of what all the different products that exist out there. And I think taking a more inquisitive approach can make it seem less prescriptive and really working with our patients, asking them to teach us. So, tell me more about the kinds of weed you use. Have you tried using weed with lower THC content? I think it's a great opportunity to learn from our patients. And by maintaining curiosity in a non-judgmental fashion, we can also prompt them to think about their cannabis use in ways that they might have not previously. I had a patient last week that I asked, hey, what's the THC content in the weed you smoke? And he was like, oh, I actually don't know, but I'm gonna go figure out. So we ended up having a great discussion around THC content, CBD content, and he left quite interested in figuring out what he was smoking and how he could do so safer. Finally, going back to the driving piece, I think driving is the one where we might have to draw a firmer line and be more prescriptive because of the common misperception, right, that many cannabis users have, that driving isn't impaired. I think we need to ensure that people who are using cannabis are doing so in a responsible manner that doesn't cause harm to other people. So really advising them, if they're using, they need to wait at least 6 hours before they drive. And if they have, work in a safety sensitive environment, then they really need to be following their occupational health and safety regulations. And for some professions, that would mean waiting 24 hours after smoking. All right, we're gonna move on to our case 2, which takes place at an inpatient unit. So you're seeing Norma. Norma needs admission for community-acquired pneumonia. She has opioid use disorder. She's on methadone, 120 milligrams PO daily, which is a stable dose for her. The only substance she continues to use is cannabis, 1 to 2 grams per day that's smoked. And as you're preparing the admission paperwork, Norma says, hey, I don't want to come into hospital. You guys don't treat me well, and it's so hard to sleep here. And back to our interactive slide here. So what are the signs and symptoms of cannabis withdrawal? You should be able to put in 3 answers and then, so you can do 1 up to 3, and then it'll appear as a word cloud. So let's give that a try. I think if more people put in the same answer, then it gets bigger. So yeah, insomnia for sure, that's a huge one. Anxiety, irritability, decreased appetite. Okay, we can talk about that. Yeah, low energy, irritability comes up a lot. Depression, low mood, yep. Okay, great. So I can see that the top three answers are anxiety, insomnia, irritability, which is correct. So I tend to think about it as, the withdrawal symptom, most of the time it's opposite to what the signs and symptoms of intoxication are. And I like to divide it into two big categories. You have your psychological symptoms and you have your physical symptoms. So the DSM-5 criteria would say, you have to have people who who are using daily, regularly for at least a few months, and then when they stop using within 7 days, these symptoms will emerge. And so the top ones really insomnia, irritability, anxiety. That's a big one, and a lot of patients fear those symptoms. And your physical symptoms can be present as well: nausea, vomiting, abdominal pain. You don't see like the cyclical vomiting as much in withdrawal, and we're going to touch upon that in our third case. And more often you would see decreased appetite, because with cannabis use, one of the effects is increased appetite. So one of the withdrawal symptoms you see is decreased appetite. The fact that we don't see withdrawal up to 7 to 10 days as a result of the lipophilic nature of THC. So THC dissolves in fat. So in heavy daily users, what happens is their fat becomes a storage of THC. So when their blood content goes down, the THC moves from the fat into the bloodstream. And so we don't really see that until much later. So when you ask your patients if they ever get withdrawal symptoms, it's really important to specify a duration of time, because many folks will be fine, right? They'll say, oh yeah, I don't have withdrawal, I don't smoke for 2 or 3 days and I'm completely fine. But really, right, that's the biphasic distribution is the reason why they don't get withdrawal symptoms until much later. And that can make it hard for people to recognize their dependence on cannabis. It's not like alcohol, quite unlike opioids. The lack of a strong, severe withdrawal symptom, that happens acutely can make it hard for people to have insight in their withdrawal and dependence on cannabis. So cannabis withdrawal happens more often than we think. Among regular or dependent cannabis users, the prevalence is about 47%. And in the inpatient setting, that increases up to 87%. So this, again, very recent data, systematic review published earlier this year, looked at a whole bunch of different studies and found, risk factors include daily use, a known diagnosis of cannabis use disorder, tobacco use, and other substance use disorders. Why is it important to focus on withdrawal? People who use cannabis for sleep and anxiety and get symptom relief, there's a possibility that that's providing short-term relief of their withdrawal symptoms. But also, when we don't address withdrawal symptoms, those symptoms can actually trigger resumption of cannabis use and serve as negative reinforcement for relapse later on. So if there are patients who want to cut down on their use, who want to stop using, we need to pay a lot of attention to cannabis withdrawal. Management, a lot of those psychopharmacotherapies that were ineffective for cannabis use disorder, those same studies actually found benefit for withdrawal symptom management. So these are some of the medications. Again, I won't go into detail, but there's a reference there for you to take a look if you're interested. Gabapentin can be helpful for global withdrawal. Your synthetic cannabinoids like nabilone can be helpful. Nabiximols are quite expensive, and dronabinol is not available in Canada. And for mirtazapine and quetiapine, those can help with sleep and appetite, especially in the inpatient setting. And so my question here is, what about replacement therapy? What about giving people cannabis directly? And so I'd like to highlight an example here from St. Paul's. During COVID, the capsule replacement program was created to help keep patients at their room, help them, decrease contact with other people. So patients are seen by the addiction team, and they can be, they can be previously using cannabis medically or recreationally, or both, and they get prescribed cannabis replacement to help avoid withdrawal. And they have two options, either a THC CBD combo or a CBD pill alone, and that's obtained from a government approved retailer, and it's dispensed in the MAR, recorded on Cerner. And it's not clear if this program will stay after the pandemic is over, but I think it's a great example of an innovative, pragmatic approach to harm reduction, right? And I think we need more of these strategies. And the reason I think why that's important is when you look at transitions in care, right? So the idea that when patients come into hospital, that is a huge transition from the community into hospital. And it's extremely difficult, often traumatic, and because they're disconnected from their social supports, patients are taken away from their baseline routines. And for people who use substances, the inability to continue use, the fear of withdrawal, symptoms of actual withdrawal, compounded with, stigmatization that occurs frequently in healthcare, can make it extremely difficult to want to transition from the community into the hospital. And I don't know how many of you have spent a night in the hospital or more, but it's honestly terrible, right? So we go in the morning and we say, how did you sleep? How did you eat? Without really considering or having an understanding of what our patients' experiences are like. And I think our current model sets patients up for failure. Whereas I think if we take a harm reduction model, I believe a compassionate, patient-centered, stigma-free approach can really help benefit our patients. It's pragmatic, it benefits our patients, but it also benefits us as healthcare providers. You have less negative interactions with patients, you foster mutual respect, minimize paternalism, and I think in many cases, right, you'll see less patients self-discharging, and that will help decrease frustrations there as well. There's also some evidence from Vancouver for patients on opioid agonist treatment, cannabis use can actually help with retention on their opioid agonist therapy, and that some folks choose to use cannabis as a harm reduction approach for opioid use. So we are going to move to our last and final case in the last 10 minutes we have. So you see Yang in the emergency department. Yang's a 15-year-old female, comes in with several days of nonstop vomiting and abdominal pain. They've had multiple visits in the past 12 months for the same thing. Investigations have been normal each time, including 2 CT scans, and the beta HCG has been negative each time. And so in this case, I'd like to bring up cannabis hyperemesis syndrome. And so the syndrome itself was first diagnosed, formulated, more often reported in the literature around 2004. And it really should be considered in your differential diagnosis of patients who present with persistent nausea, persistent vomiting, especially of a cyclical pattern over months. And associated with abdominal pain. And really interestingly, these compulsive hot baths and showers with symptom relief can be a very specific feature of cannabis hyperemesis syndrome. There have been case reports of patients who have stayed in a hot bath or hot shower for so long that they've suffered first, second-degree burns. We don't really know exactly why it happens. Different explanations, they think it's to do with, the cannabis receptors, and gastric motility is kind of the more accepted theory, but it definitely happens in people who are regular and chronic cannabis users, and symptoms resolve after cannabis cessation. It might take a month or a bit longer, but the symptoms do resolve. So let's see if the slide moves. Okay, slide's lagging. Okay, so this is our last interactive slide. How do you manage or treat cannabis hyperemesis syndrome? For those of you who've seen it or seen cyclical vomiting syndrome, how would you treat it or manage it? So this should be a word cloud as well, I think. Okay, so here I see benzos, antiemetics are the biggest word there. So yeah, lots of you are saying antiemetics, stopping cannabis use, cessation, okay, capsaicin, topical, supportive care. Antipsychotic, Zofran, rehydration. Okay, great. Yeah, so let's take a look at what evidence we have. Thanks. That was the last interactive slide. Okay. So if you look at the evidence, again, I've included a link there on a review of emergency department treatment options, but I mean treatment options in general for cannabis hyperemesis syndrome. Again, small case studies have found benefits to topical capsaicin cream. So that's just, applied topically on the abdomen. And the theory there is that it works the same way as heat on the nerve endings in the abdomen. It's not available. I think it has to be compounded, so it can be quite an expensive medication. And the burning sensation can last for quite a long time. That's been shown to be beneficial. Antipsychotics have been shown to be beneficial as well. So Haldol or olanzapine. And IV fluids and electrolyte replacement are definitely important, right? We should be doing labs in these patients and evaluating their volume status and their electrolytes. And often these patients will need lots and lots of IV fluids. Unfortunately, our conventional antiemetics are often ineffective by themselves. But what can be done is like a multimodal approach from the beginning, right? Trying your Zofran, your Gravol, and some Haldol together right from the get-go. And you can consider using like warm blankets, even a bear hugger in the emergency department to recreate the warmth sensation. What comes up a lot in the literature is that the only definitive treatment for cannabis hyperemesis syndrome is abstinence. And I mean, I guess that's true, but that's really not a harm reduction approach, right? It's like in the emergency department, we treat your symptoms and then we say, hey, you feel better now, just stop doing the thing that makes you feel bad. And somehow, we are surprised when patients come back and we get frustrated when patients come back. And I don't think, I think offering abstinence really is offering nothing for patients who come in with cannabis hyperemesis syndrome. Especially when folks it will take a few visits for them to build insight into how their cannabis use relates to their symptoms. And also when patients don't have anything else to turn to, they're likely to turn to their cannabis use to treat their nausea and vomiting because they don't have anything else. So what I propose here, perhaps, is that we see cannabis hyperemesis syndrome as a red flag for underlying cannabis use disorder, or at least, evidence of cannabis misuse, and that we arrange for follow-up or connection to addiction medicine specialist, connection to addiction counseling. It could be, if where you practice, there are no resources for that, even a letter to the GP, explaining what you found and what you're concerned about. I think that is one way, we can hopefully break that cycle of patients coming in and back in again and again with cannabis hyperemesis, especially when there's limited evidence, for brief intervention in the emergency department. When you have an obvious presentation that's related to cannabis use, that should be an obvious case that we can refer onwards to addiction specialists and to family physicians as well. And the reason why that is important, why, in the emergency department we have a role to play, is that we're seeing the latest report from CIHI, the Canadian Institute for Health Information, found that substance use accounted for 1 in 20 hospitalizations in Canada among youth age 10 to 24. So that's about 65 hospitalizations per day in Canada for youth relate to substance use. And when you look at the age group breakdowns, cannabis is cannabis is the most, I guess, #1 most associated substance associated with hospitalizations that resulted from harm by substance use. And when you look at the actual documented substances, it's quite interesting to see a good, how the breakdown differs between youth age 10 to 24 and those 25 and older. So if you look at all the hospitalizations for substance use, youth age 10 to 24, 40% of them self-reported cannabis compared to 11% in age 25 or older. And you see that shift, to alcohol at age 25 or older. So interesting, right? We see maybe the cannabis use data is showing that, youths are using less cannabis after legalization, but yet they are overrepresented in terms of hospital visits for substance use related harms. And so, we have a major public health imperative to address adolescent cannabis use, especially given the risk of psychosis that we discussed earlier in this talk, and also the fact that the youth brain is extremely vulnerable. We know that early cannabis use increases the risk of developing a cannabis use disorder later on in life, as well as, again, increasing the risk of psychosis and schizophrenia. And so I think more importantly, we need to address those individual attitudes and knowledge gaps that we see. And the Canadian Pediatric Society actually just released a practice point for health professionals on how to counsel adolescents and parents about cannabis. And I think that can be a tool that I'd encourage you to review that, especially if you work with a lot of youth, to see how you can incorporate cannabis harm reduction into your practice. So that brings us to the end of my talk. We have 5 to 10 minutes for questions, and then at the end, I'd like to finish with some last words with a summary slide. So I'm happy to take any questions right now. You can type it on the chat if you don't want to talk out loud. I can read that, or you can just interrupt and just ask your question.
Thanks, Justin. I'll get Raman. I think Raman is forwarding you these questions. I saw one just get typed in. Did you receive that?
Oh, actually, that's true. I actually can't see I can only see questions from organizers and panelists, so Raman will have to forward those to me.
I just saw a question pop up from Andrea, but then it disappeared. I don't know where that went, Raman. Oh, there it's back again. Can you see this, Justin, or I'll read it out loud?
Yeah, sorry about that. Yeah, I can't see it for some reason.
Okay, we have a question here saying, I remember there was a surge of ED visits due to high potency edibles. Is there any anecdotal or real evidence to see if the new lower dose edibles people can buy in dispensaries is having an effect on ED visits?
Yeah. I think we don't have very good information on emergency department visits. I think anecdotally, after legalization, especially after edibles were released, emerge docs were feeling like they were seeing a lot more edible related presentations. I think in children there were actual documented cases, but in the adult population, I wonder if that's also a result of self-report, right? With it being now a legal substance, patients are more likely to tell you, hey, I actually started vomiting because of this. So I think anecdotally, it feels like there are more cases, but emergency department visits are actually very hard to measure because they get coded in very different ways. So, nausea, vomiting resulting from cannabis use doesn't necessarily get recorded with an ICD-10 code for substance misuse. It could go under, gastrointestinal complaints and just kind of goes missing. And that's just the difficulty we have when it comes to monitoring emergency department visits.
Okay, another question here is what's the difference in price point between legal versus illegal cannabis, particularly in BC, I suppose?
Yeah, I only know this because I had a patient telling me about this, but he's saying how he was buying it from his friends and families, and then that would be like $60 to $80 for an ounce, but then buying from the dispenser would add like $80 or $90 on top of that. So there's that piece. I think when it comes to consuming illegal cannabis, especially if we look at weed from friends or family, we don't really know how much THC content there is. So you can talk a bit to them about the different strains of cannabis perhaps, but we won't know exactly because those homegrown cannabis plants don't get tested for THC content.
So I'll ask a question then, Justin, while people are still formulating their thoughts. I'm curious, you mentioned this very briefly, but what would you counsel somebody asking about cannabis as a form of harm reduction for opioid use or for overdose risk?
I think it would require an individualized approach, really characterizing their opioid use. I think the data was for people who were on opioid agonist therapy already, so I think that changes things. If they're coming in with opioid use and cannabis use, I think I would still, and they're not on OAT, I think I would offer that and ensure that we can, introduce that, get to a level that's stable. And then when it comes to the cannabis use, I think we need to have a detailed history on, family history of psychosis, whether or not the patient themselves have had psychosis, and then, do a risk benefit analysis then, right? Because I imagine someone who has a strong family history of schizophrenia, a strong personal history of psychosis, even though cannabis may help certain folks stay on their OAT, that might actually cause more harm than benefit.
Okay, and I know maybe I'm not sure if you dove into this, but I'm wondering if you can update us at all. Last I checked, the data in the U.S. on this subject, where they're kind of looking at state level data, was quite varied. I think even contradictory.
Yeah.
Is there any consensus building in terms of potential impacts of legalization of cannabis on overdose rates and opioid use?
I haven't seen the Canadian data, and looking at the literature, I don't think there's much reported in Canada. I think it is hard to draw, and I purposely ignored a lot of US data for this talk. I think it's hard to compare, like I guess there are two states now in the US where cannabis is legalized, but I think the drug prohibition model is quite different in the US. And so I think the fact that a lot of that cannabis is legal is different from our Canadian context. So I haven't really seen anything here on, what the consensus is.
Okay,
Hi, Dr.
I'm
Coe.
going to interrupt for a second. Peter here has a question, so go ahead, Peter.
Hi, Dr. Coe. Thanks for a great talk. I just have a question. Is it just economics that's driving the kind of illicit sector, or is there, like you said, it's not necessarily known what the THC is, but is it generally higher in the kind of illegal streams of cannabis? Like with the analog of kind of street opioids obviously being much higher potency than their legal counterparts, or is it just economics that is making people kind of continue to seek out the illicit stream?
Yeah, I think economics is a big part of it, right? When you see a big price difference between legal and illegal weed, I think ease of access too, right? If you are in a community where it's easy to get weed from your friends, I think it's easier to get it from them instead of going somewhere else to a cannabis store. I think we also need to look at the class differences, right? You look at how cannabis is marketed in legal stores and sort of a certain, middle upper class clientele that those stores cater to. I don't think it's as accessible for everyone to just walk into those stores and purchase cannabis and be treated the same way that they would, depending on their socioeconomic status and their race, actually.
Thank you.
All right. Thank you, everyone, for your questions.
Do we have any more? One last question for Justin. Yeah, one last one to wrap it up.
Perfect.
So we have a question here saying some of our youth see a career opportunity in the cannabis industry, which is not unrealistic, actually. Thoughts on counseling those youth?
Yeah. So like these are youth who want to go work in the cannabis industry. Again, I think I'd go back to that individual approach, right? Like having a conversation with the youth and doing a good risk assessment, right? Family history of substance use, any family history of schizophrenia, talking to the youth about, what their thoughts, having them lead the discussion, is cannabis something that you're interested in using or that you already use, and asking, encouraging the youth to do some sort of risk benefit analysis themselves. How can you maintain boundaries between your work and your substance use, et cetera? I think, it's a fair point that if it's a industry where they can make money, that should be something or it's something they want to do, then that's something we should support, but we can find ways to keep them safe.
Okay, and one last question here before we let you conclude. And you sort of talked around this a little bit already, but just to summarize, as far as harm reduction from cannabis use goes, do you recommend buying from dispensaries versus buying from the street? Do you recommend edibles versus inhaling? Do you have any kind of firm conclusions that you'd like to put out there?
Sure. I think buying from a dispensary, the first question, buying from a dispensary is probably safer than buying from an unknown source. So it depends, right? If they know their friends and family well and they know what sort of strains they're purchasing, that might still be a safe option. But buying from a reputable source that tests for THC content and CBD content, I think allows the consumer more control over what they're smoking. And I think the second question was edibles versus vaping. The trouble we find with edibles and is that it's hard to ration out what doses you're using. I think it goes back to the point on the variety of cannabis products we see, and oftentimes, right, you get more hungry after using an edible, and then you keep using, and then you end up using much more. So I think going back to the patient-centered approach would be to ask them what they prefer, right? And then figuring out how we can mitigate the harms associated with it. So if they're smoking and that is their preferred way of using, then counseling them on not taking deep breaths, not holding their breath, smoking lower THC content would be a harm reduction approach. If their preferred method of use is edibles, then I would counsel them on ways to measure out how much, if you're making it yourself, or figuring out the equivalents to a joint. So looking at the THC content and figuring out this is how much THC you're using if you eat one gummy or one brownie, and then mitigating the harms there. So based on what the patient prefers, I'd engage in some harm reduction around that. Hope that answers your question.
I'm going to ask one follow-up to that then, just before we conclude, is because you mentioned this a few times. I know prior to when there was still kind of the gray area around cannabis access in BC, there was lots of questions around the actual THC content of the weed you're buying in those stores. I know that they weren't particularly regulated and not necessarily particularly accurate. So how carefully is that legal weed assessed now? How, like, to what level can trust the published THC concentrations?
Right, I think initially during legalization, they found there's like a really good CBC marketplace segment on it as well, that they found like great variations in terms of labeled THC content and how much more or less it could be. I think the unfortunately, right, that isn't very regulated in Canada, and oftentimes those companies that are testing for THC have a financial incentive because it's a private company that does the testing to maintain their customers or the people who are growing cannabis. I think accepting that variability, still purchasing lower THC content would be advisable. I think we would have to look more into certain brands that have been shown to be more consistent with their THC content. And so I think despite that variability, aiming for something less and purchasing something less would still be safer than purchasing something that's marketed at 30 or 40% THC.
Right. Okay, thanks, Justin. So we'll let you bring it home with your
conclusion. Just a last slide here. So really 3 short summary points, right? But I think regardless of legalization, more and more people are using cannabis, and I think after legalization, our cannabis harm reduction has just become even more important. We need to address those knowledge gaps and attitude gaps, especially when you have companies that have a financial incentive to sell cannabis. I think our job as healthcare providers is to ensure that our patients are informed consumers and know the risks and benefits of what they're using. I think recognizing and treating cannabis withdrawal syndromes will facilitate transitions in care. And I think that goes for all substances, but particularly for cannabis with this kind of protracted delayed withdrawal period, I think it can go under-recognized, but we need to offer our patients symptom management, withdrawal management, and that will help with their transitions into hospital and help them maintain some sense of stability in hospital. And then finally, for the emergency department, again, applies to all substances, but particularly for cannabis-related presentations that we're seeing and cannabis hyperemesis syndrome. If we recognize that, that can be a red flag for us to screen for underlying use disorder and connect individuals to addiction medicine, so that we're not just sending them out the door and telling them, just stop using, you'll be better. And at least we give them something or connect them to somewhere where they can get more support and help. If you have any more questions, please feel free to email me. My contact information is right there. And or even if you just want to email me for some references, I can send you a list of the papers as well. Thanks everyone for your time.
Thanks so much, Justin. Appreciate it.